morning, world. How are you all? Just giving it another moment here. There's a lot of people registering in or coming online right now, and I just wanted to wait a moment. For those that know me, know that I like to wear a mask. Even though we got 5,000 square feet of space here and only 4 people in the room right now, I'm just doing this for you to see. All right, so I want to welcome you all to our 11th annual MS Symposium. And for those that don't know, MS Views and News has been doing this symposium for many years just in the local area. Then we started doing it virtually. And this year, of course, it's even greater virtually because there are so many people from around the world that want to see what we're doing. If you don't know, you've probably gotten a lot of my emails, but if you've never seen me before, my name is Stuart Schlossman, and I am president and founder of MS Views and News, and I did want to say hello to everybody. I'm going to give you a little bit of rundown about today's program, all right, and then we're going to get started. So firstly, MS Views and News is a nonprofit organization which provides education and resources to the MS community. Every year we provide live educational programs all around the country, and this year is our largest event, and this event is our largest event each year. We continue to do this important work today. COVID will not stop us from providing and doing what the MS community needs. We do this, like I'm saying, virtually. We are now starting to get out into some of the rural areas of the United States and trying to do some live in-person programs and bringing them to you virtually as well. Yes, it's a very tough nut to tackle right now, but we're finding ways to work with the community on doing this, and it'll work out for everybody in the future as well. So firstly, I want to give thanks. I want to give real kudos. We had over 500 people register for today's program, and I want to thank you all that did that, all right? It's a great thing. I mean, this is, it's difficult enough living with multiple sclerosis, and doing it the way that we're doing it right now and having to live in the environment that we're living in makes it a little bit more difficult. But keeping you empowered and engaged and impressed and finding people that are inspired to learn is really important to us. So again, we're glad that you're all here, and I'm glad that you all appreciate what we are doing for you. All right, going further, we want to thank today's event supporters. I don't know if you can see the whole screen behind me. I'm not on camera, so I can't see that, but these are our supporters. We have Bristol Myers Squibb. We have Mallinckrodt, we have Biogen, and we have Genentech. And virtually, let's give them a round of applause, all right? They did a great job in allowing us to be able to do this, and so we want to recognize them for what they are doing. Okay, so moving on. Last night, I emailed you a copy of the event journal. The event journal is everything to do with this program. I had to send it out in many different listings because there are over 500 registered. All right, if you did not receive that, we will be able to send it to you again after this event ends. Now, your questions. If you have any questions, on the control panel, you'll see on the right side of the screen, you could click the orange arrow. It should allow you to type your questions for each presenter. Please know that we already received hundreds of questions as everybody was registering for this event, and we cannot get to all of them, but we have sorted them out, and we'll be able to get to as many as we possibly can, depending on the length of the time of the answers that come back from the different presenters. Okay, this year we have a virtual exhibit hall. If you haven't seen it, I've sent it out many times, but for the people that registered late, if you go to our website, you can find it from there. You could also find the link for it in the event journal, okay? And it's pretty impressive. We have quite a few people that wanted to be exhibitors, and of course, we can't do that in person this year, so we have it in this virtual hall. You go to the hall, you look at the different images, you click on them, and it takes you to those different companies' websites. All right, that will remain active, by the way, on our website for another 3 months. So you don't have to do it right now. You could do it later. You could do it when you have time. All right, next, we have the people that are speaking today. So in case you haven't seen the lineup, we have Dr. Ben Thrower, who will be speaking first, and then Dr. Mitzi Joy Williams, followed by our patient advocate, Paul Pelland, who many know as Long Haul Paul. You'll hear about his story later on. And then we have Dr. Rick Harris, the psychologist, followed by Dr. Aaron Boster. So we do have a long day. Fortunately, You probably have a bathroom really close to where you are, and that's a great thing, okay? You don't have to circle the halls of a building looking for where to go. And secondly, you have food of your choice. So just enjoy whatever you're going to do. Listen to this program. You're going to have a great time. At the end of the symposium, last thing, at the end of this symposium, you're going to receive a survey through the email. Okay, we would like you to let us know what you thought about today's experience. Please fill out everything that you can. If you have anything to add to it, please add to it, and smile, okay? Let's get started. So first up, we're going to have Dr. Ben Thrower. And Dr. Ben Thrower is the medical director of the Andrew C. Carlos MS Institute at the Shepherd Center in Atlanta. He previously served as the medical director of the Holy Family Multiple Sclerosis Institute in Spokane, Washington. In Spokane, he was the chair of the Inland Northwest chapter. He's got a lot on his bio here. I'm just going to let you know that he's also the senior medical advisor to the Multiple Sclerosis Foundation. He's the co-author of a book called Navigating Life with Multiple Sclerosis, and he's the principal investigator in over 80 clinical trials. Let's welcome Dr. Ben Thrower.
And thank you, Stuart. Stuart, thank you to all of your staff and to our sponsors for making this event possible. You do a wonderful job with putting these things together. Good morning to all the virtual learners out there. Thank you for joining us. So I'm going to touch on two topics this morning. I'm going to start with just an overview of relapses in MS. What are they? What do we do about them? Why are they important? And then I'm going to shift gears completely then over into cannabis and multiple sclerosis. What do we know about it? Where does it fit into our toolbox and how we manage MS? So when we think about relapses in MS, we use a lot of different terms, and we'll go to the next slide there. So, and it's confusing sometimes because we use these terms interchangeably, and I will say that they all mean the same thing. When we say a relapse, an attack, a flare-up, an exacerbation, we're all talking the same language. But what is the strict definition of a relapse in MS? So the strict definition of a relapse in multiple sclerosis is a new neurological symptom or a worsening of an old neurological symptom. And by the strict definition, that worsening or new symptom should persist for at least 24 hours before we strictly call it a relapse. That said, we don't necessarily want you to wait 24 hours before you let us know that something's going on. If you wake up one morning and you're having new numbness or weakness in your legs, or you have visual loss, don't feel like you have to wait 24 hours. That's the strict academic definition. We probably want to hear from you sooner than that. We also need to realize that things sometimes that look like a relapse or an exacerbation may actually be due to something else going on. So we use the term pseudo-relapse. This means a worsening of neurological symptoms or a new neurological event that is being driven through something else. Heat exposure, overexertion, fever, urinary tract infection. We can't overemphasize the importance of UTIs. For many people with MS, their symptom of a UTI may not be urological, it may be neurological. So some people won't have burning with urination or pain in their back or abdomen. They're going to have worsening of neurological symptoms as their symptom of a UTI. And then we also have to realize that MS symptoms fluctuate. So, we use the term relapsing remitting MS, and when we say remission, that seems to imply that you're symptom free. But in reality, most people with MS are never symptom free. Most people are dealing with something on a daily basis: fatigue, weakness, spasticity, pain, and those baseline symptoms fluctuate. Sometimes they fluctuate and we can point to something. We can say, well, I'm stressed out. I'm living through the COVID lockdown and I'm under more stress. Sometimes we can't point to anything that's causing that baseline fluctuation. But we do need to sometimes sort out that baseline fluctuation versus true relapses. So relapses are important for a number of different reasons. One of the reasons they're important is that they are the hallmark of the most common form of MS, relapsing remitting MS. 85% of people with multiple sclerosis will start with a relapsing form of MS. And so while relapses are important, and we see on this slide, the green bars, these are the attacks that we see. When that green line goes across that dotted orange line, that's when you're having a clinical relapse. So those are symptoms that we are aware of. But as you can see, there are a lot of those green bars that don't cross that orange dotted line. These are subclinical events. These could be new MRI lesions that haven't given you any obvious symptoms. And so the point at which a person with MS comes to our attention is usually with that first green bar crossing the dotted line, a clinically isolated syndrome. But you can see there's stuff going on under the surface before that person comes in with their first attack. Next slide. So why are relapses important in the big picture? So we've said they are the hallmark of the most common form of MS, relapsing remitting MS. If every time a person had a relapse, they recovered completely from it, well, you could say then relapses are kind of a nuisance. They affect your quality of life, but if I recover from them every time, what's the big deal? Unfortunately, people don't recover from relapses every time. This was a study that looked at recovery from relapses as measured by EDSS, Expanded Disability Status Scale, the most commonly used measure of disability in MS. And they looked at people 6 months after a relapse. And what we can see on the bottom bar is that about 51% of people did recover completely in this study after 6 months, with or without treatment. Unfortunately, in the rectangular white box, you can see that some people did not recover, and 33%, a third of people after a relapse 6 months out, had a 1 point or greater worsening in EDSS. And so every time a person has a relapse, there is that potential that we have established a new long-lasting level of disability in that individual. We also know that the number of relapses that a person has in the first 2 years of their MS is very predictive of how they may do over longer periods of time. So in this study, people were broken down into low numbers of relapses in the first 2 years, 0 to 1 relapses in the first 2 years, an intermediate group, 2 to 4 attacks in the first 2 years, and then a group that had 5 or more attacks in the first 2 years. And what we see here is that the number of relapses was predictive of how soon a person would reach an EDSS, Expanded Disability Status Scale, score of 6. At a score of 6, you're using a cane. And so the more relapses you had in the first 2 years, the sooner it was that you would reach that EDSS of 6. So what do we do with relapses? Do we treat them or do we not treat them? The simple answer is that what studies have tended to show is that your recovery from a relapse is independent of whether we treat it or not acutely. And we're going to talk about some of the treatment options. But what we've seen in studies is that in general, you will recover to the same degree whether we treat you or not. We will just get you there faster by treating you. So with that in mind, some people will say, well, if they're not going to do anything, if I don't want to pursue treatment for my relapse, maybe it's minor, maybe it's numbness in a foot and it's not limiting my functional abilities or ability to do stuff on a daily basis, I'm not even going to tell someone. Even if we decide not to treat that relapse, we still want to know about it, because documenting those relapses is going to factor into how effective we think your therapy is in the long run. So do let us know, even if it's a minor relapse. So what's in the toolbox to manage relapses? Traditionally, here in the United States, we look at methylprednisolone or IV Solu-Medrol, and there are a lot of different sort of cocktails of how we might use that. We might do 3 days in a row IV, 5 days in a row IV. We might follow that with a prednisone taper. My preference is 3 days in a row and no prednisone taper. My preference is to get the benefit and get you right back off as quickly as possible. There are other regimens regimens out there. Our Canadian colleagues think we're kind of weird in the United States for using IV Solumedrol. They would argue that you could convert that IV Solumedrol over into oral prednisone at a very, very high dose and get the same benefit. And there are studies that would support that. There are centers here in the United States that in a pinch would just give someone that vial of IV Solumedrol or methylprednisolone and actually just have them put it in orange juice and drink it. So it is absorbed in the same manner just by putting it into the GI tract. And apparently it tastes pretty foul though, and that's why we put it in the orange juice. Sometimes we'll use lower doses of steroids, like a Medrol dose pack, if we're just trying to tide someone over or the symptoms are milder. So what's the downside to using steroids? There is tremendous variability from person to person in how individuals tolerate steroids. One of the things we do have to watch for are mood changes. Sometimes people feel like superheroes. They're energized and ready to take on the world with steroids. Sometimes you take that a little bit further and you get into anxiety, moving into agitation, and unfortunately we can see outright psychosis in some individuals with steroids. We can increase blood pressure, we can increase blood glucose, we can increase your stomach acid. We get a little bit nervous using steroids in people with tightly controlled diabetes or hypertension because of these side effects. We can lower your serum potassium, cause hypokalemia, and some people get an unpleasant metallic taste in the mouth. One of the things I like to do is get verification from friends and family members as to how the person with MS is really doing with their steroids, because sometimes what I hear from the individual with MS is, I got a little bit agitated with this, when in reality we see what's on the next slide, and that's just outright agitation. Some people the family members will say, I want to leave the house and get out when my loved one is on steroids, because there's so much agitation and irritability. So what are some of the other things that we have in the toolbox? We do have IVIG, or immune globulin. IVIG is pooled antibody from a large number of blood donors. This could be used in people who are intolerant to steroids or have medical contraindications, or maybe they've not responded to steroids. So this is given over 5 days in a row IV. We have plasma exchange. This is sort of like taking the bad antibodies, if you will, out of the bloodstream through a machine. So this requires a large IV, a central line type IV, and this is typically done every other day for about 5 to 7 days for more severe relapses. Usually requires the person be in the hospital to do this. And then we have a very old school treatment, ACTH. ACTH is what we used to treat relapses before there were synthetic steroids. ACTH is the hormone produced by our pituitary gland that tells your adrenal glands to make natural steroids, and this can be an alternative for some individuals. And then I work at a hospital that was founded based on rehabilitation, and I would not be doing our therapist service by not mentioning that rehabilitation can play a role in relapse recovery as well. So if you have functional limitations after a relapse, what this study showed is that if we randomize people into one group just getting steroids, one group getting steroids and the rehabilitation, the group that got the rehabilitation did better both at 1 and 3 months. And then ultimately, when we think about the best relapse treatment out there, the best treatment for a relapse is preventing them in the first place. And this is where our disease-modifying therapies come in. At the time that I put this together, there were 18 FDA-approved treatment options. I believe we're actually up to 22 now. So there's been just an explosion in the availability of long-term options to prevent relapses. And our goal ultimately these days in managing relapsing forms of MS is an acronym called NEDA, N-E-D-A, no evidence of disease activity. And what this means is the person has no relapse, no progression of disability, and no new MRI lesions. So the way that we use our toolbox of disease-modifying therapies, everything can really be broken down into one of these two camps or ideologies. Traditionally, we've used something called escalation therapy. We would start with a safe therapy with modest efficacy. And so this is maybe one of our old platform therapies, glutathione or an interferon. And then if the person didn't get NEDA, no evidence of disease activity, then we can move up to maybe a more effective therapy. Contrast this to the competing ideology, and that's induction therapy. That would mean picking a more effective therapy from day one, realizing that these therapies may have more side effect risk also. Many MS centers, ourselves included, have shifted towards this induction therapy. I really do believe that being as aggressive as we can in getting people diagnosed and on an effective therapy is going to pay off in the long run. So to sum up our section on relapses, I think the best relapse management out there is preventing them in the first place with one of our long-term therapies. Do let us know if you have new or worsened symptoms in a way that might suggest a relapse, and we do want to make sure we're ruling out underlying infections. Again, get these things documented. We'll think about, if we've ruled out an infection, we're going to think about the risks and benefits of treatment versus non-treatment. And then if appropriate, think about bringing in those physical and occupational therapy pieces. And if you're having relapses, once we've caught our breath and helped you get through this, we do need to step back and say, are we doing the best job that we can do with your long-term management? Does this mean that we maybe need to think about modifying that long-term disease modifying therapy? We're going to shift gears now and take a look at cannabis and multiple sclerosis. When we do some of our local programs here up in our auditorium, when we could, pre-COVID, live, this was always one of the most popular topics, and we usually had a packed auditorium with standing room only. Let's shift to the next slide. So cannabinoids, these are the active ingredients, the chemicals, if you will, in the cannabis plant. But there really are three different sources of cannabinoids out there. There's what we see in the plant itself. We do have an endogenous or an internal cannabinoid system, and we'll touch bases on that because that's ultimately where these molecules are working at. And then we have molecules that are synthetic, and we'll talk a little bit about some of those synthetic cannabinoids. The two cannabinoids that people are most familiar with are THC and CBD. There are many, many others out there within the cannabis plant. And we're really just starting to scratch the surface of what some of these other cannabinoids do. And also, we need to realize that the cannabis plant has more than just cannabinoids. There's another chemical class called terpenes that may have very important therapeutic effects as well. But in general, THC is our psychoactive cannabinoid. If someone's using cannabis recreationally and they're trying to get high from it, this is the cannabinoid that's doing that. CBD is the non-psychoactive cannabinoid. So how do we get cannabinoids into our body? These are the various ways. There's old-fashioned smoking, there's vaporized forms, sublingual oils in drops and sprays, topical. So cannabinoids can actually be used topically for a variety of different symptoms. And they can also be then taken orally as food or candy or gummies, any number of other oral forms. So sometimes people get very hung up on the different forms of cannabis. In general, we think of two species of cannabis. There's cannabis indica, which typically has a high THC to CBD ratio, and there's cannabis sativa, which typically has a high CBD to THC ratio. I would just know about these, but also be cautious because through hybridization and a lot of different breeding over the years, you really can't just say that there are these absolute differences between sativa and indica. If you're using cannabinoids for symptom management, you really need to know what that ratio is and not just get hung up on the label. For those of you who might be listening from states, like Colorado or Oregon, you can go into dispensaries, and a lot of these things have all kinds of names that have come out. And again, don't get hung up on the name. You really want to know about the ratios of CBD to THC in these products. So there's sometimes confusion about marijuana versus hemp. They're both cannabis, and they're really both cannabis sativa. Over thousands of years, certain cannabis sativa plants were bred to have more of a large fibrous stalk for paper, for rope, fiber, and that's what hemp is. So hemp was bred over the years to have more of a fibrous stalk. Someone who's knowledgeable, a botanist, someone who works in the cannabis field, could look at those two plants and tell the difference. They're going to be able to look at a typical marijuana plant versus a hemp plant. Say, I can see the difference. Those of us who are not in that, the botanist might not be able to appreciate that. Probably more importantly is that over the years, as hemp was bred, they didn't mean to do this, but they bred out the gene that makes THC. So in 2011, researchers discovered the genetic alteration that leads the hemp plant to produce more CBD and a lot less THC. So based upon that, in all 50 states, hemp-based CBD products are legal. So you can buy hemp oil or CBD oil. You can buy topical products. You can buy oral lozenges and gummies that are CBD. By federal law, all of these legal products can have no more than 0.3% THC. You can find some that have no THC in them. And what these tend to work for is more from a sleep standpoint, have a little bit of a calming effect. We've seen benefits with topical CBD for management of some skin irritations, eczema, psoriasis, for joint pain. Where I've not been as impressed is where these work for the MS symptoms that we really are looking at cannabinoids going after. And we're going to talk about those. Those would be spasticity, central neuropathic pain, and bladder symptoms. Next slide. So humans do have an endocannabinoid system. So we have CB1 and CB2 receptors, and these receptors are primarily present in the central nervous system and all of the immune cells. So we do make endogenous cannabinoids. We make two chemicals primarily that work at these receptors. Now, when we use an exogenous or plant-based or a synthetic cannabinoid, those plant-based or synthetic cannabinoids are working at these same chemical receptors that our natural cannabinoids are working at. So we do need to be aware that the chemistry and how these different cannabinoids work in the human body is very complex, and there are a lot of dose-related effects. You can take something like THC and it may have different effects at different parts of the brain. So when we look at anxiety, for instance, with THC, we always think of THC as having anti-anxiety effects, but it can actually promote anxiety, and that really is a dose effect, and it depends upon where in the brain the THC is working at. So when THC works in the amygdala, for instance, that tends to provoke anxiety. Where it works in the prefrontal cortex, the blue line, it tends to have anti-anxiety effects. And so these are going to really be dependent upon the individual. Different individuals have different sensitivities and the dose and the delivery system. For instance, if you were to use a cannabinoid product in a smoked or an inhaled form, you're going to tend to have that product cross the blood-brain barrier and get these very high concentrations very quickly. So maybe that's more likely to provoke anxiety in someone who's sensitive. Whereas if you were to look at an oral product, maybe it gets into the system much more slowly, and the peak concentrations in the central nervous system may not get as high. So you may get more of a sort of a sustained, milder effect with an oral versus an inhaled form of cannabinoids. So this one is a little bit busy, but what we're pointing out here is that when you look at the different doses of THC, low doses of THC tend to decrease glutamate levels and will tend to lower anxiety. Whereas if you get too much in certain areas of the brain, like the amygdala, you can actually provoke anxiety. So where are we right now with cannabinoids? What does science say about cannabinoids and multiple sclerosis? What are some of the downsides? We need to be honest and say that that not everything is all rosy. That like anything that we use as a therapy, there are potential side effects. And what does the law say in general? So I'm going to summarize the next two slides. These are position statements from the American Academy of Neurology, and I'll sum them up for you. Basically, what the American Academy of Neurology said is that if you look at three symptoms, spasticity and spasms, central neuropathic pain, burning, hypersensitivity from MS, and urinary frequency, there is evidence that cannabinoids in various forms may help with those symptoms. When they looked at tremors, at least at the time of this report or position paper, they couldn't make a good argument that there was good data to support the use of cannabinoids for tremor management. We're going to skip this, go to one more past this. Perfect, thank you. So another question is, if cannabinoids have anti-inflammatory effects and maybe neuroprotective effects in the laboratory and in lab animals, it's very enticing to question, do cannabinoids have the potential to change the long-term course of MS? Could they potentially be used as disease-modifying therapies in a way that would reduce relapse rates, slow progression of disability, prevent new MRI lesions? We don't have evidence of that yet. There are numerous research groups that are looking at this. It's an enticing question, and I would say stay tuned. We're not there yet that we could say that cannabinoids could be thought of as an alternative to our disease-modifying therapies. So for right now, I think of cannabinoids as fitting into the symptom management toolbox. So what are some of the potential side effects? This was a survey that looked at things like dry mouth, increased appetite, drowsiness. And what we saw is that the majority of people using various forms of medical cannabis did not have side effects, or they were very mild. But some 12% had moderate, and 2% had more severe side effects with cannabis. We need to be aware of the cognitive potential side effects with cannabis and multiple sclerosis. So there have been some studies that have suggested that heavy users of cannabis can see cognitive side effects. There was a study earlier this year that took a group of regular medical cannabis users in the MS community. And so what they did in this group is they let one group just continue on with their cannabis use. The other group went off for 2 months. They did neuropsychological testing, cognitive testing, before the group made any change and after the group made any change. And what they found is that the group who stayed on their cannabinoids tended to have some cognitive deficits, maybe some from MS, maybe some from their cannabis use, and that those deficits persisted when they stayed on their cannabis. The group that went off for 2 months actually saw improvements in some of their cognitive functioning. So again, that's not to say we can't use this class of molecules to manage symptoms. We just need to be aware that there could be cognitive side effects. I would argue that we could potentially see cognitive side effects with some of our prescription medicines like baclofen and tizanidine also. So it's not a deal breaker. We just need to put it on the table for discussion. This is one that people do need to be aware of. We are seeing it pop up in the emergency departments across the country, and this is called the cannabinoid hyperemesis syndrome. We typically think of cannabinoids as having anti-nausea property, but again, if you overdo it, you can actually provoke nausea and vomiting. And from what we hear from emergency room doctors, it is not fun. This is a rather severe nausea and vomiting. It tends to be refractory or not respond very well to some of our usual anti-nausea drugs, things like the Zofran or Phenergan. Interestingly, people who experience this will say they feel a lot better if they get in a warm shower. You can see this in two groups of people. You can see it in people who are using fairly heavy amounts of cannabis on a regular basis. You can also see it in someone who just on a one-time deal basis gets too much THC in their system. So maybe they've used a new form of, a stronger form of cannabinoid that they weren't used to, and they can provoke nausea and vomiting. It usually lasts for 4 to 8 hours and then will resolve on its own. The law with cannabis, we could spend hours talking about this topic alone, but you'll see on this next map that we, in the United States, we really are a patchwork of different laws. And so every state that has a law that deals with medical cannabis. Interestingly, that state law is technically in violation of the federal law. Right now, the feds seem to largely be just turning their head and turning a blind eye to what the states are doing. Hopefully, it'll stay that way until we get some sort of national, sort of homogenous federal law. So, again, you need to know what your state law is. For instance, here in Georgia, we have a CBD THC registry. I can put the person with MS into this registry. They will get a card from the Department of Public Health that will let them legally possess CBD THC oil with 5% THC versus the normal 0.3% that you see in most over-the-counter products. But do look into what your local laws are. So these are two FDA approved products. These would fall into that synthetic THC realm. So we have Marinol or Dronabinol, which is FDA approved for nausea from chemotherapy. We do sometimes pull this out of the hat to try to use for management of spasticity and spasms or central neuropathic pain and MS. And then we have Sesamet or Nebivolone that is another synthetic THC. The problem I've seen with both of these is these are pure THC products with no CBD. They tend to have a little bit more potential for sometimes causing some of the psychogenic effects that we see with THC, sometimes anxiety or sedation or people just getting outright high with that, because what we tend to see is that CBD tends to blunt some of the psychological effects of THC and smooths that out, and these again have no CBD component. Epidiolex is something interesting. So GW Pharmaceuticals out of the UK produces Epidiolex. This is a pure CBD solution. It got FDA approval in 2018 for the management of certain refractory pediatric epilepsies. The reason this is important for us to know about is it required the DEA to remove CBD from the Schedule 1 list. CBD and THC have been listed on the Schedule 1 list, just like heroin and cocaine. And so the DEA has removed CBD. We're waiting for them to remove cannabis and THC so that we can kind of keep moving forwards with the use of medical cannabinoids in MS. So we do have a product out there, another GW pharmaceutical product called Sativex. Sativex is a roughly 1-to-1 mixture of CBD and THC. It actually comes from two different plants. They have a very high CBD cannabis and a very high THC cannabis, and they actually get the molecules from the two plants, blend them together into a sublingual spray. This product has been approved by various regulatory agencies for at least 10 years in 23 other countries other than the United States. We are starting phase 3 trials on this for management of spasticity and spasms in multiple sclerosis, probably within the next 2 months. So I know for us, we're going to be a site, interestingly, to do this study. Because THC is still listed as a Schedule 1 molecule by the DEA, we had to get a special waiver from the DEA to do research with this, and that's what's really slowed most sites down in the United States. But stay tuned. One of the advantages, if Sativex does get FDA approval, which I anticipate it will at some point, is in theory your insurance company should cover it at that point. So in conclusion, for cannabis and MS, cannabis is a complicated plant, a lot of biologically active components with cannabinoids and terpenes. We are learning more every day about where this is going to fit in the management of MS and other health conditions. I do think that cannabinoids can be useful in managing spasticity, central neuropathic pain, and urinary frequency and urgency. We've got to think about the risks and benefits and costs, just like we would any other treatment in your toolbox. And you've got to know what your local state laws are. Again, we're a patchwork of confusing state and federal laws. So you work with your neurologist to figure out what your laws are. I would say if you're in a state where you don't have any access to a cannabinoid, get involved with your various groups, especially the Government Relations Committee with the National MS Society. People with MS have a loud voice in your state legislatures. Our laws in Georgia were largely changed due to various advocacy groups. Those legislators listen to us as medical professionals, but I will guarantee you they listen to moms and dads of kids with epilepsy, autism, the MS community. Your voices were louder than our medical voices were. And with that, I think we're going to kick it over to some Q&A.
Hi, everybody. So now we're back. Thank you, Dr. Thrower, for giving this awesome presentation. So now we get to the fun part. So we have Jennifer, who's in Scottsdale, Arizona, okay, and she will be calling out questions to Dr. Thrower that we received when people were first registering for the program. Okay, we have quite a few. So the doctors know, though, to try to keep their answers as short as possible, okay, but to be as knowledgeable as possible, okay? So Jennifer will be doing 2 questions, and then Jill, who's here at the studio, she'll be doing 2 questions, and then we'll go back to Jennifer and back to Jill, and whatever. We'll be doing this for about 20 minutes, okay? And then the next presentation will be by Dr. Mitzi Williams. So let's get started, okay? Take it away, Jennifer.
Thanks, Stuart. I was thanking Dr. Thrower for giving such an interesting presentation. That was really awesome. Thank you.
Thank you.
Yeah, so, I'm going to be reading these questions that came in beforehand. You all sent in so many questions, and a lot of us were communicating through email. So I'm going to start, and then I'm going to pass the ball over to Jill. So Dr. Thrower, your first question, is a non-inflammatory diet helpful in reducing MS symptoms?
Big question. Simple answer is, and scientific answer is maybe, and maybe probably. So there have been a couple of studies that have looked at low saturated fat, high lean protein, high vegetable diet. So it was one in the pediatric population that did show that kids who were on more of an anti-inflammatory diet did have fewer relapses. So we don't know that there is a perfect diet. I encourage individuals to do what we probably should all be doing. Lots of fruits and vegetables, lean protein, limit your saturated fats, and let technology catch up to you. People with MS don't typically die from their MS. People with MS die of heart disease, cancer, and stroke like everyone else. So do things that are going to minimize that. And my gut feeling is it'll probably help your MS as well.
Okay, great. Thank you. And they're shifting over to optic neuritis. What can be done for optic neuritis?
So I think with optic neuritis, number one, you'd like to prevent it. So make sure that you're on the best disease-modifying therapy that you can be on so that we don't hopefully see optic neuritis. If you do have a bout of optic neuritis sneak through, then we can think about treating it. Traditionally, that's going to be the 3 to 5 days of IV Solumedrol. We talked about some of those alternatives if you can't do IV Solumedrol. And then I think on the horizon, so let's say that you have residual visual loss from a prior optic neuritis that didn't completely recover, I do think we are getting closer to the idea of neural repair. And a lot of those neural repair studies are focusing on optic neuritis because it's a nice, easy model. Visual acuity is very objective. We have other things that we can do to measure what's going on in your eye. Optical coherence tomography, for instance, to measure your retinal nerve fiber layer. So prevent it, treat it, and hopefully repair it in the future.
Awesome. Thank you. All right, I'm going to pass it over to Jill. Jill, we have some live questions coming in.
Yes, I have a couple, Dr. Thrower. I have a question from MS Guided Bits. I had RRMS for 16 years, but after my first major relapse, after diagnosis, that actually affected my walking, I wasn't offered steroids by my MS specialist. I have never had steroids besides as a pretreatment for my DMT. I have been confused as steroids are used so commonly now for relapses as to why I wasn't offered them. I often wonder what my outcome would have been if I had been offered. It took me years to recover from severe invisible symptoms that I accessed from that relapse at 22 years old.
So we don't know, going back, why weren't steroids used? But what the studies have shown, and when a lot of this we get from the old optic neuritis treatment trial, so we've extrapolated what we see in optic neuritis over to other relapses, like her relapse that affected her walking. In general, we don't think that the disability we see now was due to the lack of steroids that occurred in the past. So what the steroids typically do is speed up your recovery, but they don't typically change where you end up in the long run. So I don't think that she would likely be in a different place now, had she received steroids back then. So hopefully that helps some. I mean, we don't want anyone to have disability, but I don't think that she's in a worse place for not having the steroids. What we really want to focus on is preventing the new stuff going forward. So being on the best disease modifying therapy that we can to prevent any subclinical under the surface or obvious stuff, progression of disability, relapses, new MRI lesions now. And I think if we can use the most effective therapy right now, the hope is that technology again is going to catch up to people like her and give us some repair strategy options in the future.
Great, thanks for that answer. Another question, this is from Karen. Does CBD gummies help with spasticity versus sublingual?
So I've not been blown away with what plain CBD, the legal stuff, the 0.3% THC or less, I've not been blown away with what that does for spasticity. I personally have found that you need the THC to manage the spasticity. And so that's where you get it. And again, when you get into the higher THC ratios, that's where you need to know what your state laws are and what you actually have access to. That's where Sativex, the 1-to-1 CBD THC. So we before we had our Georgia laws, we used a lot of just CBD, whether it's lozenges, gummies, any of those are great. But I just don't see that they manage spasticity. What I've seen plain CBD help with primarily is getting maybe better sleep, having a calming effect, maybe some anti-anxiety properties. But again, I've not been blown away with what it does without the THC for spasticity.
Thanks for that answer. Jennifer, we're going back to you now.
Thanks, Joe. So, Dr. Thrower, this person was diagnosed in 1980. Over the last 10 years, she has not relapsed, but has symptoms that are worsened. Is there anything that she can do to stop that slide of worsening symptoms?
I think her situation is one of the most common and one of the most frustrating that we see. So we see individuals that say, listen, my MRI is not changing. I don't have new lesions. I'm not having relapses, but I still feel like I'm getting a little bit worse. And what I want people listening to know is we hear you, we believe you, we know that the MRI is helpful, but it doesn't tell the whole story. We get the frustration with that. So that progression, even when there are no new MRI lesions, even though you've got a white spot on MRI here, you could have new stuff occurring within old lesions that we're just not able to appreciate on MRI. We also have to realize that as we get older, as humans, we do lose neural reserve. We lose, and so old MS lesions that maybe weren't giving you much trouble, as we lose some of that reserve status in the brain and spinal cord, maybe those old lesions start rearing their head a little bit. So even though we're not seeing big, angry new lesions or relapses, there could still be inflammation under the surface. So I still like to think about getting people on the most effective disease modifying therapy we have in her situation, his or her situation. The other thing I would say is that if that person is on treatment, what we may be seeing is their treatment stop the relapses and stop new lesions, but not stop complete progression. So even though sometimes people look like they have secondary progressive disease, if they're on treatment, we have to put a little asterisk behind that and say, but they're on treatment. What would they look like if we took their treatment away? And in some of those individuals, I think if we take the treatment away, you would see relapses and new lesions on MRI. So long answer, it's complicated, but I think the key is for right now being on managing your symptoms as aggressively as you can, exercise, rehabilitation, be on the best therapy that you can get your hands on.
Okay, great. Thank you for that answer. And now we're moving to gut health. Do you think there's a connection, or are there connections between gut health and MS?
Absolutely. And there are a lot of lines of evidence. So we know if you look at people with MS in terms of their gut microbiome, the bacteria that are in their gut, an untreated person with MS has a very different looking gut microbiome than the general population. Some studies have indicated that when we put people on an effective therapy, their gut microbiome starts looking more like the general population. We know that diet definitely affects the gut microbiome. I think the challenge right now is yes, we know there's a connection. I'm not sure we know quite what to do with that. Should we have people on probiotics? Again, should they be on a very special diet? I think it's an evolving field, but yes, there's a connection. Stay tuned. Hopefully we'll get smarter as time goes on.
Great, thank you. Jill, do you have any live questions coming in from our audience?
I do. Yes, I do. What is the typical dosing for Sativex for spasticity?
Yeah, so Sativex is again, we don't have a typical yet because it's not FDA approved. So in the phase 3 study, it's going to be prescribed. There's a titration with that dose. So they start with a certain dose and then you work your way up. They're going to cap it at a certain amount. I anticipate the way the study is going to be worked, again, set up, is that you're going to titrate and then there's a cap. But within that maximum dose, there's kind of probably be a little bit of flexibility within that dosing, depending upon what the person needs with that. But again, it is a 1-to-1 CBD, roughly 1-to-1 CBD to THC ratio in a sublingual spray. That is what we're going to see.
Jennifer, how about if we go back to you, because I've only got a couple more, so I know you've got a ton.
Okay. Can we go to the next slide, Bill? Terrific. So I know we talked about diet some during your presentation, and if you could just kind of elaborate a little bit, Dr. Thrower, on what diet you feel is best to follow.
Yeah. I would tend to look at things that look sort of like a Mediterranean diet, where you're focusing on good fats, olive oils and things like that, lower saturated fats, lots of fruits and vegetables, lean proteins. I'm not a big fan of the really fattish diets, or where you're eliminating things aggressively, where you're taking whole food groups off the table. Now, that said, we do have people that say, I want to know how I would do without dairy. I want to know how I would do without gluten. And I have not seen any consistent trends with that. If you are interested in looking at that, I would argue to be very methodical about it. So if, for instance, you wanted to see how you felt without dairy, I would make that the only change that you do. So eliminate dairy from your diet, maybe give it 6 months, see if you feel better. If you're looking at gluten, eliminate gluten from your diet, give it about 6 months, see if you feel better with it. I've not seen a consistent trend, but I have seen individuals who say, I feel better if I'm off of gluten or dairy. So I don't think eliminating one thing, a specific food is probably okay to try out.
Very terrific. Thank you. And I know this is a very common question. Supplements, what to take, what not to take, what could be good for you, what's not.
So I would recommend people take a look at a book by Dr. Alan Bowling. He's has 3 editions out. You can find it on Amazon. Bowling, just like the sport, first name Alan. He's written books on complementary and alternative therapies in MS, and a big part of that really tries to give good consumer guidance on supplements. I think that we can definitely say vitamin D is important. The majority of people with MS are deficient in vitamin D. There is some evidence that getting people up into a good normal range with vitamin D may have anti-inflammatory effects. That said, don't just willy-nilly go out and start taking bottles full of vitamin D. Vitamin D, like any of the fat-soluble vitamins, A, D, E, and K, can be toxic if you get too much. If you overdo it with vitamin D for long periods of time, you can start depositing calcium in places you don't want to deposit it, like your kidneys, and put you at risk for kidney stones. So the best thing with vitamin D is to get your levels checked and then get some guidance on replacing your dose. And what I'm shooting for is a 25 hydroxy vitamin D level between 50 and 70 for most of our folks. Turmeric. I think you can make a pretty good argument for turmeric. In epidemiologic studies, if you look at areas of the world where their diets are higher in turmeric, in say East Indian populations, they tend to have a lower incidence of autoimmune conditions. In animal models of multiple sclerosis, if we load that rat's diet up with a lot of turmeric, they tend to have milder courses of the experimental version of multiple sclerosis. So turmeric supplements are certainly available, and I think there's very little downside to using turmeric.
That's amazing. Thank you.
Yeah.
Jill, you have anything coming in on your end?
Yep. Hi. This is from Katie. Just asking your opinion. I love my Copaxone, but tire of injections. Do you see it being available in a pill form anytime in the future?
Yeah, so we've studied oral Copaxone back in the day, and unfortunately it didn't work. So we do have oral medications, they're just not Copaxone. So the oral medications that we have available for MS have a very different mechanism of action from Copaxone. What was frustrating with oral Copaxone is that in the animal model it works. So the mouse model of EAE, experimental allergic encephalomyelitis, it worked to prevent the MS activity. 2 human studies just didn't work out there. So we hear you on the injection fatigue, and we talked about NEDA, NEDA. So that's our goal in MS, just to stabilize your MS. But there really is a fourth part of what we want with MS treatment, and that's that you tolerate it. And so we get it. We have people who've been on injectable medicines forever. They've been troopers. They've stuck with it. If you do hit a wall where you just can't do it anymore, let your healthcare team know that. So there are other options out there if you do just get to the point where you just can't do an injectable anymore.
Thanks, that was great. Now I have one more question here. Is vitamin D better with vitamin K?
Yeah, so the thought of using vitamin K2 with vitamin D3, and I'll back up for a second. So you've got D2 and D3. You want D3. D2 is the plant version of vitamin D. If you take D2, your body has to convert it to D3. It works. You're going to lose a little in translation. It's better just to go to D3 right off the bat. The idea of adding K2 to D3 is that you're going to lessen the likelihood of ectopic calcification, of putting that calcium down in places you don't want it to. I think it makes sense for most people. If we have you on a dose of vitamin D, I'm going to check your D low, your 25 hydroxyvitamin D low. I'm probably going to look at your calcium. If your calcium levels are okay, you're not going high, you may or may not need the K2. If you want to add a little insurance, or if your calcium levels are running high on your vitamin D, that's where you probably want to put the K2 in. And so you can buy it over the counter, about 100 micrograms a day of K2. There is a protocol that is not FDA approved out there, where they're using mega doses of vitamin D3 and mega doses of K2. The idea being, could we get more anti-inflammatory effect with these mega doses of vitamin D and prevent the bad stuff, the kidney stones, with more K2? These are huge doses of vitamin D3. These are like 100,000 units a day of D3. I'm not ready to sign off on that yet. It'll be interesting to see what becomes of that. I'm just not so sure we can do that safely. But that is the thought behind the K2.
Thank you. Jennifer, we're going back to you now.
Okay, let's see what we have up next. So we talked about relapse. Can you discuss MS relapse, and at what point someone would use Acthar?
So Acthar gel is one of the name brands for ACTH. So that was our original MS relapse treatment back in the 1960s. That if you had a relapse, that's how they were going to manage your relapse, was with ACTH. Back then, they were using a daily intramuscular dose tapering over 2 weeks. And then what happened is there was a study that compared ACTH to solumedrol, and what they showed is that the solumedrol was just as effective as the ACTH, but it was easier. It was fewer days, shorter course. So that's where we all shifted over to synthetic steroids like solumedrol. In recent years, there's been interest in using Acthar as a subcutaneous injection for 5 days, 80 units subcutaneously daily for 5 days, and it does appear to be effective for managing relapses. It may have a lower side effect risk for some people, but what we need to realize is that what ACTH is doing, it is telling your body to make natural steroids. So if you have diabetes or hypertension, you could still see some of the same side effects with Acthar that you have with steroids. I think in general it's a little bit lower. The thing that's exciting about Acthar is that it appears to do something other than just make the body make more steroids. It looks like it does something in the central nervous system itself. In animal models, if you take that animal's adrenal gland away so they can't make steroids at all, and you give them ACTH, they still get a treatment response. So clearly it's doing something other than just the steroids. One of the challenges with Acthar gel is it has become increasingly expensive over the years, and sometimes we'll get big pushback from insurance carriers because of the price of the drug.
So is there a type of thing where you have to fail or not do as well on a certain steroid treatment in order to get approved for an Acthar treatment?
Sometimes. So with some insurance companies, they're going to want you to try that first. I have been able to get it approved where someone that has just really tightly controlled diabetes, and I know I'm going to jack their blood sugar up if I give them solumedrol. I don't need to do that experiment. And so I've been able to make that argument to the insurance carrier saying, you don't want to go there, and get them to approve it.
Okay, all right, great, thank you. And you discussed neurological reserve earlier, looking at brain health. Someone is asking what they can do daily to challenge your brain, and more information on cognitive dysfunction.
So we know that about 65% of individuals with MS have some degree of cognitive dysfunction. The most common things we see are word finding difficulty and processing speed. People with MS a lot of times have fatigue or mood changes, and so those fatigue issues and depression issues will wreak havoc with your attention and concentration. So sometimes what people with MS perceive to be a cognitive issue is really a fatigue or mood issue. The person who has poor attention and concentration with MS has a brain that looks like a kid with attention deficit disorder. So they have trouble storing new information. So it looks like a memory problem, but really it's a storage problem. So all of that is mixed in together in a person with MS, and the challenge is saying, okay, what are the big drivers for your cognitive issues? Are we making some of your cognition look worse with medications? Am I sedating you with baclofen? Are you sleep deprived because you have to get up and pee every 5 minutes? So all of those things have to be looked at together. We get a sense of that by having someone get neuropsychological testings with a neuropsychologist. That's going to document exactly what's working and what's not. We sometimes bring on board speech language pathologists for cognitive rehabilitation. They can do some of their own testing, figure out the highs and lows, and try to come up with strategies to help the person with MS function better. A lot of times they're going to have the person do some brain physical therapy, if you will. So do cognitive things, read on a daily basis, things like Lumosity, the online programs that challenge your brain. Just, I think, staying as active as cognitively as you can, so that cognitive exercise is just as important as physical exercise in people with MS.
All right, terrific. Thank you for that answer. So this is addressing fatigue. Is it best to push yourself through fatigue? And how can I overcome fatigue, especially in the afternoons? And what treatment options are there for fatigue?
So great question. Fatigue comes in two versions: neurofiber fatigue, which is exertional heat related, and then lassitude, which is non-heat related, non-exertional. I think you want to not always try, if you're exercising and you hit the wall, you're probably done for that session. So cool off, rest, relax. Don't give up on your exercise program. Stick with it, because what the exercise is going to do is going to push that line in the sand out further so that you can do more before you hit that line in the sand. We have medications to manage both types of fatigue. We have cooling strategies for nerve fiber fatigue. For lassitude, the non-exertional type, you've got things like Provigil, Nuvigil, stimulant drugs, amantadine. For the nerve fiber fatigue, the exertional fatigue, we have dalfampridine, which is the walking drug. We have the non-FDA approved version of that, 4-aminopyridine, which can sometimes help with exertional nerve fiber fatigue.
Okay, thank you so much. So big conversations to have with your doctor.
Yes,
All right, thank you, Dr. Thrower. Appreciate it.
absolutely.
All right, we're going to pass it over to Stuart.
Okay, great. Thank you, everybody. Let's thank Dr. Thrower and give him a virtual round of applause from your laptops, from your homes. Just say thank you for being here. Awesome. Thank you very much. Again, want to let everybody know who was not on earlier that we want to thank our supporters. And again, we have Bristol Myers Squibb, and we have Mallinckrodt, and we have Biogen and Genentech, okay? And I do want to thank them and hope that everybody out there thanks them for making it so we can provide this program today.